Bismillahirrahmanirrahim. Hadith of the day. The Messenger of Allah, peace be upon him, said, the deeds are considered by the intentions. Assalamu alaikum everyone. My name is Dr. Marina Akhtar, PGR Community Medicine. Today I have opportunity to critically appraise an article under the kind supervision of my worthy supervisor, Professor Dr. Saira Afzal. Title of the article is The Incident Trends of the Liver Cirrhosis Caused by Non-Alcoholic Steatohepatitis via GBD Study 2017. I am going to use Gather checklist for critical appraisal of this article. Here is the Gather checklist. Title and abstract. Identification as a global burden of disease and in abstract structure, summary, design, method, research, and conclusion should be there. As in article, the incident trends of liver cirrhosis caused by non-alcoholic steatohepatitis via GBD study 2017. This is there is identification as a global burden of disease in the title. Yes, there is. In the abstract, non-alcoholic steatohepatitis has rapidly become the most common cause of the chronic liver disease. We aim to explore the incidence and distribution of characteristics of NASH by sex, region, socio-demographic index, SDI. We collected data including sex and the region on NASH-related liver cirrhosis from the 2017 GBT study. The age standardized incidence rate, ASRs, and estimated annual percentage changes, EAPCs, were used to estimate the incident trends and distribution characteristics. Globally, incidence of the liver cirrhosis caused by NASH increased from 1,78,430 cases in 1990 to 3,67,780 cases in 2017, an increase of approximately 105.56%. The ASR of NASH increased by an average of 1.35% per year with 95 confidence interval 1.28 to 1.42. Meanwhile, large difference in the ASR's age standardized incidence rate and the EAPC's estimated annual percentage changes were observed across the regions, and the middle high SDI's socio-demographic index had the highest increase among all 5 SDIs region, following the middle SDI region. In addition, Eastern Europe, Andean, Latin America, and Central Asia showed a more significant growth trend of ASR, a standardized incidence rate. In contrast, the high STIs region demonstrated the slowest increase trends of ASR, and the high income Asia Pacific demonstrated the decreased trends among the 21 regions. Liver cirrhosis has caused a huge and the rising health burden in many countries and the region. In addition, with the growth of obesity, population, and aging, NASH might replace the viral hepatitis as the most important cause of the liver cirrhosis in the near future. Therefore, appropriate interventions are needed in coming decades to realize early diagnosis and prevention of NASH-related liver cirrhosis. So in the abstract is not structured, it is unstructured, and trial design, methods, result, and conclusion are mentioned but not in separate headings. And in the introduction section, scientific background is given. Liver cirrhosis is an important process in the liver cancer progression, accounting for more than 1 million deaths per year throughout the world. Recent studies have shown that transition from liver cirrhosis to cancer is a dynamic process regulated by the occurrence of the clinical decompensation events. Thus, the corresponding preventive strategies and treatment should be formulated according to the clinical stages of liver cirrhosis. Non-alcoholic steatohepatitis is defined as a disease with greater than 5% hepatic steatosis and inflammation with or without fibrosis. NASH is considered a common cause of the liver cirrhosis, which is due to remarkable changes in the lifestyle, geographical disparities around the world. Approximately 20 to 50% of the NASH patients may suffer from the cirrhosis within 10 years. Over the past 3 decades, the incidence of liver cirrhosis caused by NASH has varied dramatically among the countries, and total 90 million people have suffered from NASH. All these results indicated that a healthy lifestyle, appropriate interventions are needed in the coming decades. And then a few studies have been concerned with the trends in the incidence of liver cirrhosis caused by NASH around the world. And in this study, we presented the incidence trends of the liver cirrhosis caused by NASH by age, sex, region, and SDI's socio-demographic index. In the introduction, background and objective. Scientific background and explanation of rationale, and there should be specific objective or hypothesis. Yes, scientific backgrounds is given, rationale is also given. The specific heading of introduction is not mentioned. In the methods, study data, materials and methods, study data, detailed information on the liver cirrhosis caused by NASH from 1990 to 2017, available from exploration by online visualization tool. We derived from GDP 2017 study for 195 countries and territories according to SDI's socio-demographic index and the geographic location. These areas are correspondingly divided into 5 regions: low, low, middle, middle, and high SDI socio-demographic index region, and 21 regions. Details on the methods of GDP 2017 has been clarified in the prior studies. Then statistical in the statistical analysis, for the purpose of describing and evaluating the landscape of the liver cirrhosis caused by NASH incidence from 1990 to 2017, a standardized incidence rate and estimated annual percentage changes were adopted in our study. By using ASR, we could assess the incidence of NASH related liver cirrhosis and establish target preventive strategies for liver cirrhosis caused by NASH. EAPC was used to quantify the trends of ASR of the liver cirrhosis caused by NASH among the different population in a period. Both EAPC or estimated annual percentage changes a value and lower boundary of 95% confidence interval were greater than 0, indicating an increasing trend of a standardized incidence rate. In contrast, both EAPC value and the upper boundary were less than 0, indicating the decreasing trend of a standardized incidence rate, where 95% confidence interval contained 0. It indicated the constant trend of ASR. Statistical analysis was performed by our software R 3.5.1 Software Institute for Statistics and Mathematics and Stata MP. Value of P less than 0.05 were considered statistically significant. Now in the method section, describe how the data was identified and how data was assessed. This was mentioned but not so much clearly. Specify the inclusion criteria not clearly given, and exclusion criteria is also not mentioned. Provide information on all including data source and their main characteristic. No, this is also not given. Provide conceptual overview of the data analysis method. Yes, this is given but not much clearly. Provide a detailed description of all steps of analysis including mathematical formula. No, these are not given. Provide the result of evaluation of the model performance if done, as well as the result of any relevant sensitivity analysis. No, this is not done. Describe methods for calculating uncertainty of estimates. State which source of uncertainty were and were not accounted for in the uncertainty analysis. This is also not mentioned. Now we will briefly explain what is sensitivity analysis in this article. As sensitivity analysis is a method used to determine how the different input variables of a model influence its output, it helps the understanding which variables are the most significant and how changes in these variables affect the results. Input variables in this article and are demographic factors, which are health distribution, gender distribution, geographic regions, and health factor include prevalence of the obesity, prevalence of diabetes, prevalence of the metabolic syndrome, and environmental factor include socio economic status, access to healthcare, dietary habits. Data specific factors include quality of the data sources, accuracy of the diagnostic criteria for NASH and reporting practices, and output variables include incidence rate, annual incidence rate of the liver cirrhosis caused by NASH, trends over time, changes in the incidence rate over the year studies, geographical variation, difference in the incidence rates between different regions or countries. And purpose to determine which input variable, for example, obesity rate or diabetes prevalence, have the most significant impact on the incidence rate of liver cirrhosis due to NASH, and the procedure: adjust one input variable at a time, increase obesity rate by 10%, for example, while keeping the other variables constant to observe the changes in the incidence rate. And outcome: identify which factor increasing in obesity rates cause the most significant changes in the incidence rate of the liver cirrhosis. This is example of statistical analysis. And then coming to uncertainty analysis. By definition, uncertainty analysis is a method used to quantify the uncertainty in the output of the model due to uncertainty in the input of variables. It helps in understanding the range and reliability of the model's predictions. Same input and output variables, and the purpose to quantify how uncertainties in the input variables, for example, measurement errors in the obesity rate, impact the reliability of incidence rate estimate. Procedure: use statistical methods to propagate uncertainties in the input variables through the model to see how they affect the incidence rate estimate. And outcome: determine the range of the possible incidence rates, for example, 10 to 15 cases per 1 lakh population, and the confidence interval around these estimates reflecting the overall uncertainty. Now coming on the results section. Incidence of the liver cirrhosis caused by NASH. The global incidence of the liver cirrhosis caused by NASH increased 106.12% from 1990 to 2017. The countries with the highest incident cases in the world were China, where the result was 38.62 into 10 power 3, India 9.96 into 10 power 3, and Brazil 9.81 into 10 power 3, which accounting for approximately 32.68% of the total cases of the NASH related liver cirrhosis. Although China had highest number of incident cases of the liver cirrhosis caused by NASH, its growth rate was lower than the global average level. Moreover, 35 countries of 195 countries accounting for 80.25% of the global incident cases, and total of 129 countries and territories, most of which were developing countries, experienced a prominent increase of more than 100%. Among all countries, highest growth rate of the incident cases were found in UAE, followed by Qatar and Oman. In this period, liver cirrhosis caused by NASH was more common in men. However, the ratio of male to female slightly decreased from 1.47 to ratio 1 to 1.37 ratio 1 during the study period. The A-standardized incidence rate and the estimated annual percentage changes of the liver cirrhosis caused by NASH varied considerably. Globally, the age standardized incidence rate increased by an annual average of 1.35% per year, from 3.31 per uh, 10 for 10 lakh to 4.81 per 10 lakh. The highest standardized incidence rate was found in the Mexico in 2017. Regarding sex, the standardized incidence rate showed a highest growing trend globally in the female than male from 1990 to 2017. That is explained in table 1. We will discuss later. Among the 195 countries and territories, 177 countries and the territories showed an increased trend in a standardized incidence rate of the liver cirrhosis caused by NASH. Moreover, 113 countries and territories demonstrated faster growth of a standardized incidence rate than the global average. In contrast, 14 countries demonstrated that decreasing trend of ASR, including South Korea and others. A gradient upward trend of the incidence rate was observed across the five socio-demographic index regions instead of the continuous growth trend. The incident cases most significantly increased in the middle STI region, followed by the high middle STI region. Additionally, the incidence of liver cirrhosis caused by NASH only increased 43.75% during the study period in high STI region, which was the region with the lowest increase in number of cases among five STI region, socio-demographic index region. These are area maps showing the diagram A showing the incidence cases in 1990 across the world, and this diagram B incident cases in 2017 across the world, and this picture C showing the change in the incident case of liver cirrhosis caused by NASH from 1990 to 2017 across the world. And this is the tabular presentation of the results where characteristics are sex, male and female, and social demographic index and the regions are mentioned. The incidence cases, age, standardized incidence, and temporal trend of the liver cirrhosis caused by NASH between 1990 to 2017 explained in this table. And again, this is the area map, picture A, picture A and B. Picture A showing that uh, picture A is showing that ASR, a standardized incidence rate of liver cirrhosis incidence caused by NASH in 1990, and picture 2 is showing the A standardized incidence rate in 2017, and picture C is showing that ASR trend of the liver cirrhosis caused by NASH from 1990 to 2017 across the world. And this is the diagrammatic representation of the liver cirrhosis incidence cases caused by NASH and STI region from 19 to 2017. This is the graph bar of the this is showing global and the low social demographic index and low middle social demographic index, middle social demographic index, high middle social demographic index, and high social demographic index. Now coming on the discussion section, this research analyzed the trends in the incidence of the liver cirrhosis caused by NASH globally, contributing to optimizing the allocation of the health resources, improving health outcomes for the patients suffering from NASH-related liver cirrhosis. Obesity and metabolic syndrome are considered the main risk factor for NASH-related cirrhosis. Moreover, obesity were more common in the developed country. However, the gap in the obesity prevalence between developed and developing countries is narrowing. Comparing to the Western countries such as America and UK, the country as the Arabian Peninsula and Asian countries such as UAE and India also have high level of obesity and metabolic syndrome. Our study also found that incidence was evolving in the Asia and Eastern Europe. This might be related to sedentary lifestyle and overnutrition, high fat foods, lack of exercise. Diabetes might affect the lipid metabolism, induce NASH related liver cirrhosis. Moreover, the process of NASH related liver cirrhosis might be accelerated. Additionally, the Western lifestyle might also be responsible for increasing trend of the NASH related cirrhosis in these areas. Studies have found that there may be a large number of non obese people in the developing countries such as China, India, Mexico suffering from the NASH induced cirrhosis. Patients with lean NASH have been shown to have higher mortality and shorter survival time after liver transplantation. And our study demonstrated that a standardized incidence rate increased during our study period, especially in the high, middle, and middle socio-demographic incidence regions. And the limitations of our study, GBD study, lack data in remote villages or some countries. This might affect the estimated trend of the NASH-related cirrhosis. In addition, GBD data of the liver cirrhosis did not include the data of the risk factors such as BMI, diabetes, blood lipids. Therefore, we could not further analyze the risk factors of the NASH-related cirrhosis. Moreover, it is impossible to explore the relationship between BMI and the NASH by using GBD data. Finally, due to the lack of the relevant data such as BMI, blood lipids, we could not study the trend of the lean NASH in GBD study. Now the GBD study has been updated to GBD study 2019. In our study, we use the date from GBD study 2017. The item B dot 4.1.4 of the liver cirrhosis were changed from the cirrhosis due to NASH in 2017 to cirrhosis and other chronic liver disease due to uh, non-alcoholic fatty liver disease in 2019. The definition of the NASH changed, the number of the patient and the trends also changed dramatically. According to the previous definition of the cirrhosis due to NASH in the GBD study 2017, the relevant data have not been updated in the new version of GBD study 2019. Moreover, the study used data in the cirrhosis and other chronic liver disease due to NAFLD from GDP study 2019, which might be completely different from use data on the liver cirrhosis due to NASH from GBD study 2017. Thus, this study was not suitable for updating the data from GBD study 2019, and we will use the new data of GBD study 2019 in our further studies. In conclusion, NASH is emerged as the most common cause of the chronic liver disease worldwide. Due to lack of awareness of NASH and misdiagnosis, the actual incidence of NASH-related cirrhosis might be underestimated. Therefore, it is greater significance to make liver cirrhosis caused by NASH is an urgent public health priority worldwide. More targeted medical and public measures should be initiated and implemented immediately. And other information, funding is also given. Open access author contribution and acknowledgement is also mentioned. In the result and discussion sections, find the indicator population, including age, sex, and geographic entities, and the time period for which estimates are made. Yes, it is given. List the funding source of the work. Yes, it is given. Provide published estimate in a file format from which data can be efficiently extracted. Yes, this is given. Interpret result in the light of the existing evidence. Yes, it is mentioned. Discuss limitations of estimate, including discussion if any modeling assumptions or the data limitation that affect interpretation of the estimate. Yes, it is given. Provide all data input in the file format from which data can be efficiently extracted. No, that is not mentioned. Identify and describe any categories of input data that have potentially important bias. No, that is not mentioned. Report a quantitative measures of uncertainty of estimate. This is also not mentioned. Strength of this study is title is self-explanatory with type of study. Methodology is explained. Geographical representation of result is present. Discussion includes comparison and contrast with other studies. Area map for global burden disease is given. Results are represented in the tabular and graphical form. Limitation of the studies are given and mention the funding source of the work. Limitations of the studies are abstract is unstructured, no specific heading of abstract are mentioned, no specific heading of introduction is mentioned, inclusion and exclusion criteria is not mentioned, data sources are not well defined, biases are not addressed properly, They did not provide a detailed description of all types of analysis, including mathematical formulae. They did not provide the result of evaluation of the model performance as result of any relevant sensitivity analysis. They did not report a quantitative measures of uncertainty of estimates. This is the YouTube link of our channel, and kindly like and subscribe, and thank you so much.